Hello, everyone. Thank you so much for joining. We're very happy to have Dr. Raafat with us today. We're presenting some of the cases that we've done at MRC for the oncological applications of PET MRI. Dr. Raafat is an eminent figure at MRC and pioneering in advanced MRI body applications. She's a member of the Egyptian Society of Radiology and European Society of Oncological Radiology. And we're very happy to have her with us today. This is one of the some of the series that we've done of webinars for the PET MRI applications. As you all know, MRC is the first to install the PET MRI in Cairo and Africa at large, and we're very proud to have that. And without further ado, I'll leave the speaker with Dr. Wafaa. Dr. Wafaa, if you could share the screen just to make sure that we can all see it. Okay, I can see it now. If anyone is having any problems with the voice or anything, please let us know at any time. And of course, we will leave some time at the end for questions and discussions. You can raise your hand if you have a question, or you can leave the question in the comments, and I can just say it out loud if you'd like, or you can just raise your hand and tell us your question right away. Dr. Wafaa, the floor is all yours. Thank you.
Thank you very much, Wafaa, for this introduction. Thank you. Can you hear me properly?
Yes, we can hear you, Dr. Wafaa.
Is the voice okay? Okay. Thank you very much for this introduction. Thanks to all of you for attending. I would like to share with you some highlights concerning the PET MRI oncological applications. We've been having the PET MRI for about a year and a half now. We've seen a lot of the cases, so we have a really nice learning curve with a lot of experience with different oncological cases. So we would like to share this experience with you and to highlight the importance of MRI and when and in which cases to call for an PET MRI. So as regards the updates in PET MRI oncological applications, as you all know, we have the first PET MRI machine in Africa and the Middle East, and so we are so proud of this. Simply, the PET MRI is using, it is a hybrid imaging technique where the PET detector is embraced within the MRI machine. Simultaneously, we have PET and MR images which are fused together to give us the both anatomical and functional data taken from not only the PET but also the MRI. So as you all know, we are fusing the metabolic data which is acquired from the PET with the functional and high resolution anatomical data acquired from the MRI. Now, the benefits, I guess we all already know the importance of PET CT. We are now going to highlight the importance of integration of MRI in this hybrid type of hybrid imaging. First of all, we've got the high resolution MR images, which we use for anatomical localization of the lesions that show abnormal FDG uptake, together with utilizing the signal characterization of MRI, because we use also MRI in the characterization of lesions based on their different signal intensities on the various MR sequences. Of course, we have the diffusion weighted imaging and ADC maps, so we can qualitatively and quantitatively assess the cellularity of different lesions. We have the perfusion and dynamic contrast studies for both qualitative and quantitative assessment of the contrast handling and the vascularity of different lesions, which is also helpful in the characterization of lesions and in the staging of their aggression, so the degree of aggression of the lesion. There is also the spectroscopy, which is a metabolic tool used in MRI which is tailored according to the need of the patient in different oncological settings. Now, triaging the oncological cases according to our experience over the past year and a half, we found out that simply we are talking about a one-stop shop examination, which includes local staging and characterization of lesions together with the coverage of the whole body. So in a single examination, we are doing local staging and distant metastatic assessment, including nodal, soft tissue, and osseous assessment in different lesions. We found out that the most influenced cases, or the cases where we found PET MRI to have an edge in, include, of course, the breast, because MRI helps in the detection of multicentricity of different breast lesions. And lobular carcinoma is one of the tumors which have variable affinity to FDG. In most of cases, they have a low affinity, so MRI plays an important role in the characterization of the lesions and in the staging, in better staging as regards the whole body assessment. We have also the metastatic HCC, because we all know also that there is the normal uptake, background uptake of the liver for the FDG. So there could be an element of obscuration of small lesions where MRI may have an edge, especially when we resort to the diffusion weighted images. We have also the pancreatic tumors. We all know the edge and the importance of the MRI multiparametric dedicated pancreatic studies, incorporating the high resolution MRI, the MRCP, diffusion weighted images, which are extremely important in the staging of pancreatic tumors and the assessment of resectability from irresectability. There's also the renal cell cancer, and this is also where MRI, or the integration of MRI, may have an edge because of the normal excretion of FDG through the renal excretory system. So there is also, there could also be an element of obscuration of renal malignancies, especially when we're talking about small tumors. And again, the integration of MRI helps in further characterization and assessment of extent of involvement. There is also the ovarian malignancies, in the staging of ovarian malignancies, because we are talking about the importance of MRI in the local staging, the assessment and characterization of the different ovarian lesions, and the spotting of the distant metastatic assessment, which of course includes the peritoneal involvement. We have also the prostate tumors, the cancer prostate. Of course, the MRI is of utmost importance in the local staging, so combining it with the distant metastatic assessment is of utmost importance to verify the load of tumoral involvement in different patients. There is also the rectal and colonic tumors or cancers, where we also know the importance of MRI in the local staging, local TNM staging, and the assessment of the perirectal fascia and the mesorectal, the perirectal fat planes and the mesorectal fascia, and assessment of the resection margins. Together with, in addition to the distant metastatic assessment based on the whole body coverage. Together with also the metastatic musculoskeletal, different metastatic musculoskeletal malignancies. Now, the benefits of PET MRI include the lower total ionizing radiation, because we are only, the patient is only exposed to the PET component, while MRI does not include any ionizing radiation. Although there is a longer scanner time, but we use this, or this is helpful in the improved accumulation of tracer for better delineation and assessment of the lesions. Also overcoming the pitfalls of in FDG uptake in some of the lesions where there is intrinsic low affinity to FDG, including the low-grade lung adenocarcinoma, renal cell cancer, mucinous neoplasms, and the lobular breast cancer. There is also the availability and the importance of the fact that we can perform a PET MR study without the need for MR contrast agents in patients with renal impairment and contrast hypersensitivity, giving us accurate data based on the non-contrast enhanced perfusional and diffusional sequences. We also perform tailored MR studies for each cases. So in a case of breast cancer, it differs from a case of lung cancer, from a case of prostate cancer. And so this tailored protocol applied for the MR study gives us the edge of high resolution and important accurate data for local staging. There is also the importance of MRI in the characterization of inconclusive marrow lesions when there is in a setting of malignancy, and there are inconclusive lesions on other modalities. It is important to accurately say, does this patient have osseous metastasis or not? So we are utilizing certain sequences in MRI that help us in this accurate characterization. There is also, of course, the MRI having its edge in the central nervous system metastatic affection, the neural axis, including the brain and spinal cord. Also, we all know the importance of MRI in the detection and characterization of brain lesions, lepto and pachymeningeal infiltrate. I won't go deep in the differentiation between PET-CT and PET-MRI. Now, the essence of this talk is to highlight the importance of PET-MRI and when to order it for which patient or for whom of the oncological patients. I'm going to show you some examples of cases performed over the past year in our center to highlight the role of PET-MRI and where it has edge and how it has been helpful in assessing and in staging patients. Now, this is a case of breast. The first case is a case of breast cancer that was treated 30 years ago, presented with vague abdominal pain. Her CT study revealed ascites and smudgy pelvis. This is her 3D Q-Clear, the PET study, showing abnormal uptake in the pelvis together with sheet-like and spotty focal abnormal uptake in the peritoneal cavity, the abdominopelvic peritoneal cavity. This case turned out to have a bilateral adnexal, i.e. ovarian, malignant tumoral lesions being more sizable on the right side compared to the left side, with metastatic peritoneal deposits showing a rather heavy peritoneal metastatic load, as demonstrated in the uptake, the sheet-like uptake and the focal uptake seen within the abdominopelvic cavity. This is furtherly supported by the MR, the fused or the adjoint qualitative and quantitative assessment of MR and PET tools. As we can see here, the increased uptake in FDG with an SUV max reaching about 14. The smudgy heterogeneous appearance of the lesion on T2 fat suppressed image. This is the fused T2 and FDG images, PET images. We have the T2 weighted image again, showing this heterogeneous lesion, which shows significant diffusion restriction with a low mean ADC value of 0.9 times 10 to the power -3 millimeters square per second, consistent with the cellular packing. This is just to show us the example of these peritoneal nodules, again showing the uptake on FDG and the focal diffusion restriction with cellular packing on diffusion weighted images. This is an example of a case which showed us that the patient had developed another tumor, another malignancy, after about 30 years of prior breast cancer. We have another case here of metastatic pancreatic adenocarcinoma. This is her fused, this is the case's fused PET MRI. We can see that, as we all know, the importance of MRI in the local staging and assessment of the vascular bed, whether we can see here, as we can see here, the encasement of the celiac trunk, Of course, we rely on axial, sagittal, and coronal images for the detailed assessment of the pancreatic tumor and its relation to the celiac trunk, the superior mesenteric vessels, together with the other related structures, the duodenum, the jejunum, the splenic hilum if it is arising from the tail, or the hepatic hilum if it is arising from the pancreatic head. Where there's also the integrated MRCP study showing us the double duct sign with the pancreatic duct dilatation together with the intra and extrahepatic biliary radical dilatation. We can see here the perfusional status. This is a colored image, perfusional image showing the relatively hypoperfused state of the lesion. And this is the fused PET MR study showing the uptake of the FDG uptake of the lesion. And then this patient had metastasis in the liver. Again, we can see the uptake on FDG, focal uptake on FDG, the hypo-enhancing lesions on the dynamic phases, together with the dynamic phases, together with the diffusion restriction related to the primary tumor and the focal low ADC values, or the frank diffusion restriction related to the the hepatic focal lesions. There was also peritoneal involvement in this case, peritoneal nodules. This is the largest nodule which we encountered insinuating between the urinary bladder and the rectum. The patient also showed metastatic involvement of the lungs. Now, adding the 0TE has given us an edge in scanning the lungs, because previously MRI had certain limitations related to the assessment of the pulmonary parenchyma and the detection of small pulmonary nodules. This has been to some extent overcome by the integration of the 0TE, and it is furtherly combined with the PET showing us the focal nodular metastatic involvement. So in this case, we have the detailed local assessment, including the high resolution MRI pancreatic protocol, together with the whole body metastatic survey, incorporating the 0TE chest study that has overcome to a certain extent the limitations of MRI in chest imaging and delineating small pulmonary nodules. Here is another case of histopathologically proven cecal cancer, which was coming for staging. As we can see, there is the abnormal uptake here, the FDG, high FDG uptake related to the cecal lesion. And furtherly, you can see focal abnormal uptake in the liver. There were hepatic metastatic lesions. This is the primary cecal lesion with metastatic involvement, not only nodal as regards the right internal iliac lymph nodes, but also osseous lesions, various osseous lesions. These are the hepatic metastatic focal lesions, which show diffusion, which show variable degrees of diffusion restriction and concentric diffusion facilitation, giving rise to the target appearance of these lesions with the peripheral low signal on T2 weighted image, fat suppressed T2 weighted images with the central high signal, which could in part be attributed to the mucinous nature of this tumor, which shows delayed variable degrees of delayed enhancement, and it appears also hypo-perfused on the perfusion color map. We also have the heavy osseous metastatic load through these combined outfused T2 and PET images, showing the involvement within the spinal, within the vertebrae, at various levels, together with the iliac bones, and also within the both femora. This is another case which had a right lumbar paraspinal neoplastic lesion and was coming for further assessment. It was considered based on the MRI done as a metastatic lesion, so the patient was coming to detect a primary. Through the whole body survey, we can see that there is abnormal focal uptake scattered. This is the lesion which was formerly assessed and reported on the MRI, showing the FDG uptake, focal large area of FDG uptake, and then we can see scattered nodules of osseous FDG uptake along the spine, the whole spine, together with variably implicating or involving the ribs, the iliac bones, together with the right femur. This is the lesion of concern, where we can see it is seen arising from the right aspect of is spanning from L2 to L4 vertebra, with extensions extraspinally, together with the insinuation in the aortocaval recess, together with direct abutment and indentation of the inferior vena cava. This is the fused MR PET image showing the localization of the lesion and the extension, the high FDG uptake of the lesion. Moment. These images show the involvement of the variable involvement of the vertebrae, starting with C2, together with dorsal and lumbar vertebral involvement. This case was furtherly or histopathologically proven to be a lymphoma with a heavy osseous involvement rather than nodal and soft tissue involvement. This is another case of invasive ductal carcinoma, which was coming for initial staging. As I mentioned earlier, the importance of MRI is in terms of breast cancer is not only the verification or the characterization of the lesion, but also the detection of multifocal or multicenteric involvement, the involvement of the contralateral breast, and furtherly the whole body survey in assessment of further nodal, osseous, and soft tissue metastatic involvement. Now, in this case, we can see that there are three focal areas of FDG, preferential FDG uptake in the right breast. Furtherly, we have the fused PET MR images also showing us these lesions within a dense, fibrodense breast or dense fibroglandular breast. The lesions were pinpointed based on the diffusion, showing focal cellular packing preferential compared to the rest of the fibroglandular tissue in the breast, together with the high FDG uptake, with further assessment or further detailed assessment by a dynamic contrast study, showing us that the focal areas of abnormal contrast enhancement also shows type 3 time intensity curves with a sharp upslope of contrast uptake and acute downslope of contrast washout, and furtherly showing focal areas of preferential diffusion restriction compared to the background normal diffusion behavior of the fibroglandular breast parenchyma. Furtherly, this patient showed brain metastasis together with intraparenchymal lesions seen within the cervical and dorsal cord. So in this case, we can see the detailed local assessment showing the multiplicity or the multi-centricity of the lesions implicating the upper and lower lateral quadrants of the right breast, together with the whole body metastatic survey with accurate assessment of the neural axis affection. This is a case with a surgically removed sigmoid colon coming for follow-up. The comparison was made with a previous MR study that showed a left internal iliac lymph node that increased over time. As we can see, it is more sizable with eccentric hilar fat. And furtherly, we can see that this lymph node shows accentuated FDG uptake. What was interesting in this case that we not only found this solitary lymph node that is acquiring PET MR features of active neoplastic involvement, but there were also there's nothing here. There were also there was also involvement of the liver through these metastatic hypo-enhancing lesions, which were standing out as focal areas of diffusion restriction. But also what was surprising in this case that we found a lesion in the peripheral zone of the prostate with showing a relatively hyperperfused acquiring low signal on the T2 weighted images with diffusion restriction on the corresponding diffusion weighted images. Showing a relatively hyperperfused state and relative FDG uptake. This was furtherly proven by biopsy to be a prostatic adenocarcinoma. So we were able to detect another lesion in this case where the patient was coming for follow-up as regards its primary sigmoid colon malignancy. This is a case of metastatic breast cancer that was on chemotherapy and coming for follow-up with agonizing back pain. She underwent breast reconstruction. The malignancy was on the left side with the reconstructed breast showing no abnormal uptake and no abnormalities on MRI. On her previous PET-CT study, there was nothing conclusive. There was only this small focal area of slight FDG uptake. And on the follow-up, a dedicated MR study, including in-phase, out-of-phase diffusion, perfusion, and the fused PET data, showed that this accentuated FDG uptake with the hyperperfusional state, the diffusion restriction, together with the, this is the in phase and this is the out of phase. Normally the fatty marrow shows this drop of signal when compared. Now we have a bright marrow signal on T1 in phase sequence that normally drops on the out of phase sequence. We can see that this lesion of concern shows no drop of signal. It is standing out as bright signal on the out of phase, which is supportive of its infiltrative neoplastic nature. So we were more confident in calling this a metastatic deposit rather than a questionable osseous lesion within the lumbar vertebra. Furtherly, the patient also had metastatic lesions in the liver. There was this lesion showing the FDG, the accentuated FDG uptake. It shows it is hypo-enhancing with a faint rim enhancement on the portovenous sustained on the delayed phase. There was also another tiny lesion that could be relatively missed on the FDG study, as we can see here. But then again, it is pinpointed on, and again, it could be missed on the post-contrast dynamic study due to its small size, but it was depicted as a focal area of preferential diffusion restriction on diffusion weighted images. Furtherly, the patient also had a comparison was made as regards the osseous metastatic involvement. As we can see that some of the lesions showed progression in the FDG uptake over time. Other lesions were stationary. This is another case with histopathologically proven left breast lobular carcinoma and inconclusive vertebral marrow lesions on bone scan. This is her Q-Clear 3D PET image, and this is her local breast assessment. Now we can see that there is the heterogeneous involvement of this is the heterogeneous clumping of abnormal enhancement seen along the lateral aspect of the breast. We can see that the main bulk of the tumor is at the upper outer quadrant, but a tongue of tissue was seen spanning or extending to the retroareolar region with the resultant retraction of the nipple. We can see that this study is a multiparametric MR study of the breast integrated in the whole body assessment. So we have the dynamic study, we have the diffusion, as we can see with the diffusion restriction. This is the ADC map showing the cellular packing related to the lesion, together with the abnormal perfusional status or relatively hyperperfused state compared to the parenchymal perfusion on the contralateral side, together with the type 3 time intensity curve plotted. These are the fused PET MR images showing the variable FDG uptake with areas of accentuated FDG uptake and areas of less FDG affinity. The lymph or the nodal assessment, we can see that there is also the diffusion restriction and the accentuated FDG uptake related to the anterior and the central group left axillary lymph nodes, also showing a type 3 time intensity curve. These are the coronal fused images, also showing the primary breast lesions and the left axillary metastatic lymph nodes. And then we can see here the also in phase, out of phase, post-contrast T1 PAT-SAT image, sagittal image, and the fused PET MR image showing no frank metastatic lesions. Again, we can see that there is the drop of signal comparing the in phase to the out of phase sequence, which is faintly sparing some degenerative fatty marrow signal alterations appreciated in relation, as we can see here, in relation to the end plates. The last case here is of a treated left lower limb osteosarcoma. The patient was presented with a bilateral upper limb paresthesia. Now this is the MRI, whole body MRI and PET study. We can see that the patient was treated by surgery and prosthetic replacement. So we can see that there is the inevitable metallic artifacting appreciated at the left lower limb. The patient showed no de novo lesions, no metastatic involvement elsewhere in the body, but what we found that explained the patient's symptomatology were these foci of signal, bright signal on FLAIR, okay, and T2 weighted images. They are these small foci, okay, seen here at the centrum semioval region and bifrontal subcortical regions, together with within the cord. You can see that there are also these lesions. The patient turned out to have primary demyelination. Now, the idea here is that we are minded that this is a whole, this is a patient as a whole. We are not only pathologically minded with a cancer, so we are searching for only metastasis. The importance of this whole body survey can give us answers to certain symptomatology that is not explained by metastatic or neoplastic involvement. So we can consider PET MRI as a frontier between what was done in hybrid imaging before and what is done in hybrid imaging now. So it is important to choose which modality is best for each patient. It is considered one of the one-stop shop examinations, so there is less time and money consuming. The importance of answering as much questions as possible. So the dealing with each case as a unique setting to be tailored. So we tailor each study as much as possible to give you the utmost or the most, to give you as much answers accurately as possible. and then overcoming the pitfalls. And what is important, as I have discussed in the above cases, is dealing with the patients through a holistic approach and not only being pathologically minded with what the patient is definitely coming with. Thank you very much.
Thank you so much, Dr. Wafaa, for this amazing presentation and for your effort in putting it all together. If anyone has further comments or questions, please let us know. Dr. Yasser, do you want to say anything? I see you unmuted.
Yes, first of all, I would like to thank Dr. Wafaa so much for this nice, innovative, and enlightening presentation of something that is relatively new and difficult to grasp and interpret, but she managed to walk us through it very eloquently and highlighting, at least to me, where and when should we order PET MRI as a one-stop shop exam that answers so many questions at one point of time. To sum up my question to Wafaa would be, if you can give us your best 3 indications for the oncologist to when he has a cancer, especially newly diagnosed cancer patient, when should he order for PET MRI? And the same thing is after treatment, in the post-treatment setting. So when should he order PET MRI and when should he order something else?
Okay, thank you very much, Dr. Yasser. As for the first question, if I'm going to triage 3 oncological settings, I would say, of course, breast, because initially we are talking about the importance of MRI in the local staging. Now, what was common is the patient does an MRI, a high-resolution dynamic contrast study on the breasts, and followed by a PET CT. So I'm talking about a one-stop shop examination that includes the local staging with the assessment of multicentricity and multifocality, together with the coverage of the whole body. So, of course, the breast. And then we have also the gynecological lesions, now the ovarian lesions, because also MRI has its edge in the assessment of ovarian and also uterine and uterine malignancy. So in addition, when we are talking about staging, because again, the patient does an MRI of the pelvis and a PET study, PET CT study. So I think it would be much better for the patient to do a single study covering both local and the distant assessment. And then we have the pancreas. And I would add also the GIT, I mean the rectal malignancy, and the followed by the colonic malignancy. So I would put 4 now: the breast, gynecological, the rectum, and followed by GIT, and the pancreas, because we know that MRI has its edge in the local staging, and then adding the metastatic assessment in pancreatic adenocarcinoma. So this is the first question. In the follow-up of patients, no, this could be widened. Now, there are some things that come inconclusive on CT. So we are, when we talk about مثلا PET CT, in the follow-up of certain lesions, so we are relying on the uptake on FDG. There are some pitfalls in FDG or some degrees of overlap between benign lesions and post-irradiation changes. So MRI may have its edge, especially when I'm talking about marrow lesions that are inconclusive, and I want to know, is this patient responding to radiation therapy in a certain region. يعني انا مثلا targeted radiation to the spine, targeted radiation to a certain lung bone. I think in the follow-up on MRI, because we are furtherly characterizing, not only relying on the FDG data, we give more informative points.
Yes, okay, thank you, Dr. Wafaa, for elaborate answer. I see Dr. Khalid Naeem is with us. I think he's muted, and we would like to hear from him. Any questions, comments?
Thank you دكتور ياسر. أنا سعيد بمتابعة المحاضرات اللي بتعملوها، حاجة فعلا بنستفيد بيها. أنا يعني raising يعني two questions. Is there any direct studies comparison between PET CT, MRI PET as regard the sensitivity and specificity? The second question, احنا كأونكولوجيست امتى ما نبعتش العيان للام ار اي بيت؟ يعني هل في حاجات مش هتضيف جديد لو بعت العيان؟ وتكمله لمناقشه حضرتك الفولو اب بتوع العيانين and how to criteria for response والكرايتيريا اوف ايفالويشن ديت ريسيست كرايتيريا على اساس ان احنا هنكمل على نفس التريتمنت ولا هنبتدي نغير الديفينيشن اوف ستيشنري اند بروجريسيف، خصوصا لما يكون الفرق بسيط او يكون يقل الحجم وتزيد الاس يو في شويه. هل دور الام ار اي بيت في الموضوع دوت يا ريت to be clarified.
If I may, before Dr. Raafat goes ahead to just يعني اجاوب لحضرتك انه الفايده في البوست تريتمنت سيتنج انا شايف انها كبيره جدا في الام ار اي، علشان خاطر بيبقى عندنا كذا بارامتر تو توك اباوت. ذكرت الريزيست كرايتيريا، يعني وي هاف سايز بارامتر. عندنا كمان في الام ار اي نفسه كده، لما بتكلم في جزء الام ار اي ما دخلتش في جزء البيت. الام ار اي عندي سايز which is more precise عن اي موداليتي اخرى، لان عندي كذا سيكونس بشتغل بيها. اقدر افرق النكروزز من الهيموريج من السوليد كده بري وبوست كونتراست ام ار اي. وبعدين بنتقل الى الديفيوجن والاي دي سي. هنا عندي برضو كواليتيتيف اسسمنت بنظرتي انا كاكسبيرينس، ايه الحتت النكروتيك، ايه الحتت الهيموراجيك، ايه الحتت السوليد اللي هي عامله ديفيوجن ستركشر جامد. كمان عندي بارامتر اللي هو الاي دي سي فاليو، ده بقدر استخدمه فيري جود بارامتر، وعليه طبعا ليترشر كتير جدا جدا في البوست تريتمنت سيتنج where things are going. انا I am using it in my neuro cases a lot. نخش بعد كده على البرفيوجن. والدكتور وفاء ورت الحالات بتاع ازاي ان كل الحالات بنعملها معاه البرفيوجن اللي هو تي 1 برفيوجن using كي ترانس. فعندي الكي ترانس بارامتر ده برضه very solid vivid بارامتر، يعني يمكن حتى في البروستات كانسر واخد ايدج يمكن اكتر من اس يو في في البوست تريتمنت سيتنج بالذات، انه بيقدر يقول انا لسه عندي هايبر برفيوجن، فمعناها لسه عندي فايبل تيومر تيشو اور ذا ريفيرس. فاذا all these are integrated in a multi-parametric way plus بقى الاس يو في اللي حضرتك بتتكلم عليه، بلس ان الاس يو في بيبقى مور اكيوريت في السيتنج بتاع البيت ام ار، لان المريض بيقعد فتره اطول في الجهاز. فوي هاف مور بيت داتا كالكوليشن تساعدنا ان احنا نبقى مور اكيوريت سبيشالي في السمول ليزنز وكده. قلت انا في الاجابه، بسيب الدكتوره وفاء تكمل.
هو في بارامترز كتير قوي بنعتمد عليها زي ما دكتور ياسر قال في الام ار اي، مش بس السايز. فاحنا ممكن as early as يعني مثلا 1 month to 2 months بنقول ان البيشنت ده is responding or not at cellular level، لان احنا معتمدين على baseline perfusion و baseline diffusion او diffusivity يعني cellular packing، فنقدر منها اشوف changes قبل ما يحصل changes في السايز او changes في المورفولوجي ان في gross necrosis او whatever يعني. فده الايتم بتاع الفولو اب. احنا بالنسبه لنا لما بتكلم على sensitivity والspecificity it varies، يعني there are variable values based on the pathology. يعني انا لما اجي اتكلم انه انا هترياج الحالات according to انهي هيديني data more reliable عن يعني كموداليتي ما بين البات MRI والبات CT، فاحنا بنتكلم على الحاجات اللي هي مش notable في السي تي، مش هيبقى reliable قوي ان انا ابقى معتمد على بس الميتابوليك ابتيك. بمعنى ان انا دلوقتي لو انا عندي ليجنز الافينيتي بتاعتها مش عاليه للاف دي جي، فانا من الاول لما هعمل البات سي تي انا هبقى relying على changes في السي تي كدنسيتي وكتكستشر وكابيرنس عن ان انا ابقى معتمد على البات او الاف دي جي ابتيك. فممكن يبقى ده اندر ستيجنج للكيس، بمعنى انه مثلا and we've seen these cases actually، ان انا لما يبقى عندي مثلا mucinous adenocarcinoma wherever، يعني في الركتم في الباول في يعني في الكولون او في الجي اي تي، الاسسمنت بتاعه كبرايمري كميتاستاسيس هو اوريدي الاف دي جي بتاعه ضعيف، الابتيك بتاعه ضعيف، فانا محتاج حاجه تديني ريزوليوشن عاليه عشان اقدر اعمل ديتكشن للليجنز، عشان اقدر اقول اعمل accurate staging للكيس. اللوبيولار كانسر في البريست، بعض السب تايبس بتاعت الانفيسيف داكتال كارسينوما في البريست. فانا اقصد ان انا فكره ان انا في المطلق اقول كومباريزون ما بين البات سي تي والبات ام ار اي ان انا هختار انهي، لا مش ما فيش solid figures، لكن الكومباريزون تعتمد على الباثولوجي. يعني هقول مثلا ان انا هعمل ليمفوما، لا I can do PET CT in case of lymphoma. In an established او advanced lung adenocarcinoma هعمل PET CT. لكن لو انا بعمل triaging وكومباريزون ما بين ان انا هعمل مثلا في gynecological malignancy، انا محتاجه ابقى شايف الليجن بالاكستنت اوف انفولفمنت بالبريتونيال ديبوزيتس حتى الصغيره، فانا بكومباين البات مع الديفيوجن مثلا عندي في الام ار اي، بكومباين البات مع التي 2 والتي 1 في الاسسمنت اوف ذا ادنكسال ليجن. فانا يعني فكره في المطلق ان انا احط comparison ما بين البات سي تي والبات ام ار اي، لا it depends on the different pathology. فلما انا بعمل triaging او بختار لعيان او عيانه هتعمل بات سي تي او بات ام ار اي it is on this. يعني انا لما جمعت الكان انتي اللي هم including زي ما قلت اللي هو البريست والبنكرياس والريكتم والبروستات، لان انا I have an edge في الريزوليوشن وفي الفانكشنال داتا اللي بتطلع من الام ار اي added to the functional data اللي باخدها من البات. هل في سؤال تاني؟
لا فيري جود فيري يوسفول. ولذلك السؤال اللي بعد كده اللي هو امتى ما ابعتش العيان، يبقى انت حضرتك يعني عايزانا نركز على التايبس بتاعت المالجنسي الى حد ما طبعا دول اللي هو
ممكن اقول بس ان في ابسوليوت كونترا انديكيشن اللي هو قصه الام ار اي بقى. يعني انا دلوقتي لو العيان ده بركب كوكلير امبلانت اللي هم للام ار اي، يعني في absolute contraindications to MRI، فانا في الحاله دي مش هعمل الحاله للبيشنت ده مش هينفع يعمل ام ار اي اصلا، فاكشلي فديفنتلي مش هينفع يعمل بات ام ار اي اللي هم يعني الحاجات اللي هي الكوكلير امبلانتس والبيس ميكرز والحاجات اللي هي دي. يعني
مش عارفين البني برضو شرايح ومسامير والحاجات دي برضو بتبقى مش كبيره.
دلوقتي المواد المستخدمه بقت فيها يعني بعض المواد بتبقى compatible انه يدخل يعني يدخل الام ار اي ديفايس.
تمام.
زمان كان في حاجات فيها it's not compatible وما ينفعش يعمل ام ار اي، دلوقتي لا.
معظمها
والother elements which are used now لا they can do MR study.
وهو معلش باي ذا واي هو مقفول، مش هو لازم يبقى مقفول ولا انا ما يعني
مقفول
لازم مقفول، يعني مش ما فيش حته ان هو يبقى ام ار اي مفتوح يعني.
لا.
تمام.
انا يعني I have also a comment برضو باخده من النقاش المثمر ده بين الدكتور خالد والدكتور وفاء. حضرتك بتقول انا امتى ما بعتوش يعمل ام ار اي، وانا الحقيقه معلش انا ممكن اقول لك هو انت امتى انك انت you have a better chance of totally evaluating the case with PET MRI بصرف النظر طبعا عن الحاجات اللي هي البيس ميكر والكوكليا امبلانت والكلام
لا
ده.
انا ما قصدتش خالص الكونترا انديكيشن
هنحطه ده يعني هنحطه على جنب. ليه بقى؟ لانه sometimes you don't know او many times you don't know the nature of the tumor you are dealing with. فلو انا I don't know the nature of the tumor، هل هو من النوع اللي هو مش هيبقى هو intrinsically كده ما بياخدش avid uptake of FDG؟ طب ما هو انا لو قعدت نعمل PET كده هيبقى اندر دايجنوز واندر ستيج واندر ما اعرفش ايه. لكن انا في البيت ام ار اي عندي بيت وعندي كل الحاجات بتاعت الام ار اي. ما اعرفش يعني انا شخصيا بفكر فيها بالطريقه دي. انا كده على الاقل ضمنت ان انا الام ار اي هيساعدني بالبارامترز بتاعته الكواليتيف والكوانتيتيف، وكمان عندي البيت داتا اللي كنت هاخدها. اوكي اند وي سي ذس يا دكتور خالد كل ذا تايم. يعني احنا عندنا كيسز، حتى انا شايف الدكتوره رشا صلاح معانا كيسز في البروستات كده، تلاقي بروستاتيك كانسر ما تفهمش واحد بياخد فيري افيد بي اس ام اي اكسبريشن والتاني لا، وبعدين يطلعوا باثولوجيكالي بروفن كانسر. البنكرياس زي ما الدكتوره وفاء قالت، وريفر يجور ريكتم، الاوفري كده. فانا شايف ان I think that the best bet would be by initial staging by PET MRI and follow up by PET MRI، بس برضه provided ان الناس اللي بتعمل PET MRI، عشان برضه حته البيت ام راي احنا عاملين لنفسنا كده طريقه او سكول ان احنا بنعمل فول كومبريهنسيف مالتي بارامتريك انديكيتد ام ار ستادي. ممكن تلاقي في حتت اخرى حتى يمكن بره مصر كمان بيستخدموا البيت ام ار اللي هو ايه، ان انا ببدا العيانين اللي انا مش عايز اديهم راديشن زي الاطفال ومش عارف ايه وغيره بعمله كبديل للبيت تي، لكن ما ببقاش مهتم قوي بالجزء بتاع الام ار. لا احنا في مصر الاشعه ولله الحمد بنعمل الفولست مالتي بارامتريك ام ار ستادي بلس البيت ستادي. عارف اذا كانت الدكتوره رشا تحب تعلق في الجزئيه دي على موضوع الكانسرز اللي مش بتبقى افيد دي، لان هي كمان بتشتغل بيت سي تي وبيت ام ار. طيب يعني لو رشا ما كانتش افيلابل، لو في حد يحب يكومنت any other comments او questions. شايف حد سأل questions على number of coils او كده بس تاه مني في النص.
There's a question من دكتور مي معتز asking how many coils are used in the exam.
هي الكويلز بتعتمد على الجزء اللي انت بتيفاليويت. يعني في الهيد كويل I think 30 something، البودي كويل دي عدد يعني لو بنشتغل في البودي في الشيست ابدومين وبلبس، بعد كده بتنزل على الني وهكذا. يعني هي مرتبطه بالجزء اللي انت بتفحصه، ودي بتبقى حاجه فاريبل من جهاز لاخر. طبعا في 3 تسلا الكويلز بتبقى اعلى واكتر وكده. ف يعني اللي انا اقدر اعلق لك عليه بالنسبه لي انا في النيورو at least we need 32 channel coils. Anybody else wants to add something? Or everything is.
Dr. Mai, does this answer the question? Okay, sure, thanks. If you have any further comments, please let us know. Please go ahead and type the question if you'd like, or just raise your hand, or just unmute and ask the question if you have any comment or question.
يعني أنا
اتفضل دكتور.
يعني أنا I think for me that المحاضرات بتاعت البيت ام ار دي مفيدة لأنها enlighten us all to this hybrid combination. يعني نخلي بالنا إن دلوقتي يعني كل حاجة بتبقى عايزة مالتي بارامتريك واي اوف ثينكينج وابروتش وكده. فكون ان انا افكر في حاجه لوحدها، الام ار بقى في اغلبه دلوقتي مالتي بارامتريك، بالذات في الهاي اند كيس. بنعمل فيه كونفنشنال بري وبوست كونتراست وديفيوجن وبرفيوجن وسبكتروسكوبي وسنسيتيفيتي اتسترا. كمان جاي معانا اهو البيت ام ار. وكمان الناس دلوقتي دايسه جامد في مختلف انحاء العالم، بالذات في الصين وامريكا، في الارتفيشال انتليجنس الاي اي وهكذا. فالفكره ان احنا لازم كلنا يبقى برود مايند كده، نتجه دايما الى ان احنا بنحاول نجد في الاكزامينشن بتاعنا طالما العيان جاي وهيبقى ايفالويتد، give him the best of all worlds. يعني مش حتى both worlds، لا. يعني انا دلوقتي لو انا عندي artificial intelligence I would add it to the PET MRI to give the highest most comprehensive information. لانه الدكتور خالد طبعا عارف الكلام ده، لان such initial high end information هتخلينا نحطه في المنطقه المظبوطه بتاعته من الاول. ده هيأثر رحله العلاج وهيخليه ياخد الحاجه البروبر. وكمان في الفولو اب نقدر نديتكت اي ايرلي تشينجز، ايرلي ريسبونس، ايرلي وهكذا. فهو دلوقتي الحاجات دي كلها الفلسفي دلوقتي ان احنا نحاول نلم اكبر قدر من الانفورميشن كواليتيف وكوانتيتيف وبمختلف الطرق، عشان ده اللي هيخلينا نبقى on the right track initially and post therapy. This is my يعني overall comment for this.
يعني انا سعيد بالكومنت بتاعك يا دكتور ياسر، واتمنى انه يبتدي يظهر الاستاديز في انعكاس المور ريزوليوشن مور هايبريد على الاوفر اول سرفايفل العيانين الانكولوجي، سواء ان احنا نتدخل بدري زي ما حضرتك بتقول او نغير بدري. بس اعتقد ان الموضوع without يعني اكيد في كوست عالي للمور اكريت دايجنوزز دوت يعني.
هو طبعا كوست، ما هي كوست بنفيت ريليشن شيب يا دكتور خالد. يعني ان الكوست اللي بيدفع هيبقى اقل بكتير من انه يبقى الانسان اندر ستيج او اندر دايجنوزد او وات ايفر، او يبقى فيه رحله طويله ومعاناه اكتر. فبالتالي
هتبقى من حاجه في حاجه. صحيح.
هتبقى يعني هو في مثل يقول لك ايه، الغالي رخيص، عارف ازاي؟ فانا بحب امشي بالمثل ده في كل حاجه. اللي هو يعني لو واحد بيشطب شقه، ولا ربنا يديكم كلكم فيلل كده في كل حته، اكيد لما بيعمل الانفراستراكشر بتاعها كويس جدا من الاول ويصرف عليه كويس، ده هيوفر عليه اجوني ومينتنس وحاجات زي كده ليتر اون. يعني هي فيلوسفي.
لا بالعكس، انا ما قصدتش الكوست على ثمن الام ار اي البيت ام ار اي، انا قصدت على الكوست في تكلفه العلاج الناتج عن المور اكيورسي. انت يعني مور ديتكشن يبقى more choices of the treatment which يعني more expensive للبيشنت. هو ده اللي قصدته. هو طبعا الهايبريد ام ار اي ما اعتقدش ان هو يعتبر غالي في رحله العيان والتكلفه، لكن بالعكس هي ممكن تخليني انا ككلينيشن يعني او كجراح ما ابتديش اعمل عمليه لعيان عيانه بريست وهي اوريدي عندها ميتاستس من الاول وتخش في رحله وتاخد علاجات على اساس انها لوكالايزد وهي اوريدي ميتاستاتيك. فشور يعني الهايبريد اكزامينيشن is useful for the patients.
تمام حضرتك. وانا حتى يعني عندي حاله لسه قريبه مني في العيله كمان، حد عنده رينال كانسر، وبعدين لما اتعمل بروبر ساعد الجراحين جدا ان هم يقدروا يشيلوا، لان الرينال كانسر طالعه on top of مالتي سيستيك او سوري بوليسيستيك كيدني. فطبعا لما بتقدر تفرق which is the cancerous lesion من الكومبليكيتد سيست بهذا النوع من الهايبريد ايمجنج، يقدر ياخد العلاج الناجح سواء جراحي او غيره على طول، بدل ما كانت الحاجه دي تبقى ميست واندر دايجنوز وتؤدي الى نتائج وخيمه وتبقى ميتاستاتيك بعد كده. دي لسه حاله حاضره في الذهن يعني. طيب. Okay. I think now we can stop here and announce بقى دكتور ضحى when is the next lecture.
Yes, we're planning for another one on the 30th of August, and of course, we'll be sharing with you all the details. And this webinar is also recorded, so we'll be happily sharing with you the recording. And of course, we're here anytime. Please feel free to reach out to us on email, or our email is medical_info@misrradiologycenter.com. This is the dedicated clinician's email, or on our phone numbers, Dr. Yasser's or Dr. Wafaa's. And stay tuned for the announcement for the upcoming webinars. And thank you so much for attending. We know it's a busy, hot day, so we appreciate your time. I'll write the email also in the comments.
Right. And I want just to end by giving Dr. Wafaa the gold medal on the occasion of the Olympics. She deserves the gold medal. Okay. And there are no bronze and silver today. So Wafaa gets the gold medal. Okay.
Thank you very much, Dr.
Totally agree.
Thank you, Dr.
Thank you so much for attending, and have a great rest of your day.
Thank you.
Thank you very much.
Bye-bye.